actually to invite back up Krishna Rocha-Singh, my very good friend and colleague from Viva. And Krishna is going to talk about optimizing outcomes with carotid artery stenting.
Thank you, John. I was given the title that was, I think, open to interpretation of optimizing outcomes of carotid stenting. And I want to reflect a little bit upon some of the comments made by Dr. Moore and understand some of the comments made by Dr. Martin previously, that we can look at the same data, we can read the same paper, and we can come to different conclusions. What I'm going to suggest that in the next 20 minutes or so is really looking at this data and defining quality of care. Because as someone who's been stenting carotid since 1997 in the wall stent trial, I think all of us have the interests of our patients at heart. And we understand that, as far as I'm concerned, and I think a lot of cardiologists, our crest has changed a lot. And I think there's an establishment of equipoise in certain specific patient populations. These are my disclosures. I am on an advisory board of at least several companies that make carotid stents. That really has nothing to do with this talk. So here's a case presentation. I want you, first of all, I always like understanding who I am talking to. How many of you stent carotid arteries? Okay. How many of you were CREST investigator certified, got the little CREST pin, and put it on your lapel? Just one. How many of you were CREST certified surgeons? One. So I think that's actually a very interesting comment with regards to some of the issues here, because I do think, to Dr. Moore's point, I think it's all about, just like anything else, experience and judgment and knowing what you're doing and being there a lot. And that's what we want for our patients. So let's go through this. And I want to reflect on this later on in my talk. And I want you to answer the question to you. So 65-year-old gentleman, okay, think about CREST, think about the SPACE trial, think about EVA 3S, think about all the trials that we've had. Here are the typical risk factors: 2 months, 2-week history of amaurosis, question mark, look at these symptoms: right-sided hand weakness, typical coterie of medications, and here's his physical examination with a left-sided bruit. You do have an indication to do a carotid duplex Doppler that you'll get reimbursed for, not necessarily because of the carotid bruit, but concern of stroke, and then your neurological examination. And you could be a general internist, you could be a cardiologist, you can be an ER doctor. What do you do with this patient here? Here is his ECG. Here's his carotid duplex Doppler done by an ICAVL certified laboratory, suggesting a high-grade stenosis. The MR is also done in a collaborative manner, and this patient is being set up to define the best medical therapy for him. And so what would you do next? And just answer this question. Would you, if you're a neurologist, say discontinue the aspirin and add BID Agranox, like they do frequently with regards to patients in this category, potentially? Would you immediately hospitalize this patient, heparinize this patient, and call a surgeon and say, I want an OR slot for this patient the next morning? Or would you say, I'm going to add clopidogrel? Dr. Moore alluded to that, and refer to an endovascular specialist, whether a surgeon or a cardiologist or a endovascular radiologist, for consideration of carotid stenting. Or would you say, the hell with it, I'm just going to start some Coumadin, warfarin, because that's what I've done for so many years? Well, here's our first case back July 1st, 1997. And I show you this case to understand that we have evolved. We have evolved exceptionally in the past 14 years. This was the first stent that we did as part of the wall stent trial, which was a randomized prospective evaluation against a peripheral wall stent over an 035 system, 8 French, and no distal protection. This was in the roll-in trial of the wall stent that was never completed because of, guess what, poor stent results. And the patient in this case did well and went home 48 hours later. And so the fact is that in the past 14 years, we have seen, as I mentioned, incredible progression where we start considering a evolving endovascular therapy and match it against a mature surgical procedure that has more than a half century of experience behind it. We now have obviously evolved to get dedicated systems. In the past 14 years, we have a plethora of data that we can analyze and discuss and debate with regards to high risk and now standard risk patients now that we have the CREST trial. And we have multiple medical societies giving us guidelines with regards to credentialing and patient indications. But unfortunately, we've also had, and I think we've got over this, as Rodney King said, can't we just get along? We've also had, unfortunately, at times some acrimonious debate among specialties with regards to patient selection and accreditation and indications. We've had publications, I think, of not so good randomized controlled trials that get published in very high-level impact journals like the New England Journal, and we can pick apart EVA 3S and the SPACE trial. We've also understood that the publication, I do believe, and I think I agreed with Dr. Laird, has changed a lot amongst at least the cardiologists and those open to consider other options for their patients. And then, as Dr. Laird suggested, we've had the big hand, as I've suggested to you in my previous talks, coming in, and this dichotomy between reasonable and necessary, i.e. CMS, and safe and effective, and we'll talk a little bit about that later. Now, Dr. Laird just did right off the hot press the 2011 guidelines. Here it was back in 2007, and I want to show you all the societies that were joined in this. And I think the absence of SVS in this consensus document was the sign of the times. If you go back to John's slide, SVS is now part of this. And having been the past involved deeply in the ACC, we were involved in many acrimonious discussions on how to proceed, but thank God we are moving ahead. But still we understand that what if you ask, are the current indications, we need to understand that we have to, as an interventionalist, most of us believe that the current trial results would suggest that carotid stenting is appropriate for most high-risk patients. But if you ask a surgeon, I still think most of them believe that moderate to high-risk patients are treated with carotid endarterectomy. And I think if you ask most neurologists, like John suggested, they still believe that asymptomatic lesions should be treated, regardless of how high-grade or progressive they are, should be treated with medical therapy. My point is we all have our own realities. And so let's take a look at some of the things that we have to understand. We have to critically evaluate the data presented, and I applaud what Dr. Moore did. And we have to review the inclusion-exclusion criteria and the relevance to our practice, understanding that 85% of the people that we see are never included in randomized controlled trials. And we have to understand, were these adjudicated endpoints by independent neurologists? Was there a DSMB? And what was the experience, both of the surgeon and the doctor doing this stent? So if I'm an internist, and I can tell you after EVA 3S and the SPACE trial hit the New England journals, referrals for carotid stenting just went away. Because the fact was, they thought medical therapy is now the way to go. And here's something that was published in Stroke back in December of last year, suggesting to us that asymptomatic patients do just fine, and here's the data to prove it. We see that there have been diminishing stroke rates as far as Dr. Abbott's concerned, with medical therapy alone. As a neurologist, she strongly believes that Agrinox is the way to go. That's her reality. And she said here, the best evidence now indicates that medical intervention is now at least as effective in preventing stroke and TIAs as combined interventions with endarterectomy. And so here you go. talking to a neurologist, talking to a general internist, we all have our own realities. But what's wrong with, if you critically analyze, like Dr. Martin suggested that we do, we have to understand, what is the cocktail? Did they get statins, but not just statins, but statins to goal? That's G-O-A-L. Did they get their hypertension to goal? And so what about the plaque? Not all plaques are created equally that are treated medically. What about patient compliance? What about side effects? And in the randomized trial here, we haven't had one looking just at medical therapy alone versus an intervention. So what are carotid stent outcomes tied to? And I think it's no surprise to anyone in this room what they're tied to. They're tied to the patient, symptomatic, asymptomatic, over 80 years, and this thing that we call carotid reserve with regards to their tolerance of the procedure. The anatomy, obviously, difficult arch, tortuosity, calcification, all the things that as interventionalists we sort of run the other way from, and we understand these patients are not ideal. But we understand that the two things that I'm most concerned about, frankly, besides the patient, is the operator and the learning curve, the case judgment and selection that judgment brings. And then finally, I think, from my point of view, we've almost reached a commodity state with regards to distal protection devices. Now, that may be a little hyperbole. I think really what I would want to suggest is that many of us pick a device that we're most comfortable with, and we know how to use it and what it can do and what it can't do. So these are the main four things that I think some of the outputs, the results are tied to. And if you are doing carotid stenting, this type of patient should not be your first patient. Someone who has a very tortuous extracranial internal carotid, that has a high-grade long stenosis, that has a moderate significant amount of calcium. And then for me, one of the most telling factors, as you can see here, I call it the mandibular maxillary sign. If you have less than 10 teeth in your mouth, that's a bad prognosticator as far as I'm concerned. And you may laugh, but it's true. So this is something else we run from. We've learned that circumferential calcium is not something that's appropriate for stenting. We know that if you do put a stent in here, and this is a stent that I did years ago that I probably would not touch today, only because circumferential calcium, we know with regards to technical results, is not the best way to go. I don't know how John feels, but I look at that and I frequently will take a patient off the table if my duplex ultrasound has not given me all the information or my CTA has not given me all the information with regards to circumferential calcification. Calcification is a bad thing, and I add that to age 80. Along with an arch. Now, Dr. Moore looked at EVA 3S, claiming that this was the creme de la creme. But let me give you another perspective, because I read the same paper and I've come to, I think, a little bit different conclusion. And again, I just point this out to suggest to you, read the data, come to your conclusion, and think critically. He's 30 centers, 500 patients, symptomatic patients, endpoints, death and stroke, so forth and so on. You saw the results here that really set the applause for carotid stenting in favor of, carotid endarterectomy in favor of carotid endarterectomy with regards to symptomatic patients. But we'll have to look here with regards to 4-year outcomes. We have, again, stroke and death. Again, we have preponderance of disabling stroke, and I agree that's bad, that disabling strokes are a bad thing with regards to quality of life. And here you see 4-year follow-up with regards to ipsilateral stroke, any stroke, and stroke myocardial infarction. And you see that after 30 days, however, there's probably no increase, no significant increase once you get 30 days out. But let's look a little bit deeper with regards to the procedural experience that was glossed over with regards to those doctors who were doing the carotid stenting. Now, if you had carotid stenting, you needed to do at least 12, right? And you need to do 35 great vessel angiograms or an angioplasty or a balloon on a vertebral or a subclavian. But 12 is what got you into the game. And with endarterectomy, you got to do 12 in the preceding year. Now, I don't know what it is in your state, but I understand the typical vascular surgeon does less than, what is it? What's the number now? Dr. Moore, less than 20 carotid endarterectomies a year? You know, that's what, a couple a month, counting holidays and vacation. So my point here is that experience is everything, and you can see the decline in stroke as we have gained that experience through PMA's trials. So my takeaway from EVA 3S is that experience matters, experience matters, experience matters, and that carotid stenting outcomes with EVA 3S with symptomatic patients are higher than those observed, as John suggested, in U.S. post-market surveillance. Again, I think that reflects the experience of doctors. And then, as I alluded to, that once you get past 30 days, it looks like the stroke and death rates are essentially equivalent. Now, CREST, I'm not going to regurgitate this because, again, this is where I take a look at a trial as a participant in this trial for the past decade or so. And I do want, again, applaud Dr. Moore for realizing that there was a very strict credentialing process, and more than 50% of the cardiologists that wanted to get involved were kicked out. They said, you're not good enough. You don't do enough of them. I don't know what it was on the surgical side, Dr. Moore, but you know, I think there was here attempt to say experience matters, and you need, if we're going to compare oranges and oranges and a device that's been available for 5 years as opposed to a procedure that's been available for 50 years, we at least have to have the experience of the operators. Now, I must admit, and Dr. Moore, I'm a Bruin too. I was a medical student there. You probably don't remember me with Dr. Longmire back in the day, but I have to say as a cardiologist, I strongly disagree with you when you downplay the importance of a myocardial infarction. This is not no harm, no foul type of thing. And I do think that the separation, here you see some of the data that was presented here. You do see here death, stroke, myocardial infarction in the combined cohorts. You see them now out to 2.5 years, basically no difference. You see the primary endpoints, and I agree that you have to maybe tease apart this, and I do agree with all the comments from Dr. Moore in that regard. But I must admit that this issue, you know, if I'm a cardiologist and my vascular surgeon, and someone's just had a post-op MI and they're in the ICU, you know, and this is a big deal. I'm not going to tell them to call a plumber. You know, it does affect patients' lives. And what he did not suggest is that we know as cardiologists that if you do have a STEMI or a non-STEMI myocardial infarction, that is a major predictive of future morbid and mortal events due to cardiac events. His issue with regards to clopidogrel is an excellent issue. Our surgeons now operate on a regular basis on clopidogrel. They've come to understand that they can handle that because they feel that they can get better results for their procedure on doing carotid endarterectomies. And I agree also that 80-year-olds, when I get an 80-year-old with a high-grade asymptomatic stenosis, I'm telling myself, okay, statin, dual antiplatelet agents, a lot of education, and I look at the velocities, I look at the plaque morphologies, because I do agree, I do not see a lot of 48-year-olds with high-grade asymptomatic or symptomatic carotid disease. I do see more of these. And getting back to our gentleman here, we do see that in CREST, 90% of the patients enrolled fell into that. And then with regards to Mr. Smith, I think, is right in the middle. But so, you know, we all have to make our own judgments. The fact is, surgery is a good deal. I'm blessed at our institution with vascular surgeons that don't do more than 20. They do a hell of a lot more than that. So my conclusions for CREST really are that I think we've established almost equipoise, frankly. Fewer myocardial infarctions, we can't dismiss those. We should not be dismissive of myocardial events and the arrhythmias that follow and the prolongation of hospitalization that occurs and so forth and so on. Younger patients do better. Older patients, I've had it, I send them to my surgeons in that regard. But what happened, and this gets back to what John was saying, while CRUST was going on. While CRUST was going on, everyone was getting their game up. And we see what has happened with regards to events, major adverse events, between those 6 years. They have gone down considerably. And so we know what the post-market surveillance trials have done for us in large cohorts of patients, talking about thousands of patients. We have gotten better. We have gotten better with regards to symptomatic patients and, asymptomatic patients and symptomatic patients. You know, the data you showed from Germany suggested that the cutoff is about 150 patients, right? I can tell you what happened with CMS has dropped significantly in our practice, the ability to do carotid stenting. And although we are in the same PMS trials, that our volume of carotid stenting has declined substantially. And I'm concerned that whatever CMS does, understanding the panel approved, the FDA panel recommendation was to approve the CRUST data and to allow for standard risk therapy. I'm concerned that getting back on the horse for many of people who haven't done at least a decent amount of carotid interventions on a regular basis, we may be reinventing the wheel. So I want to check a little bit here in my last 4 minutes here about something that was alluded to by John. There is the real world that we live in, and then there are randomized controlled trials where we don't really live in, only a relative small number of patients. This is hot off the press, published online just last week. This is a referral pattern change for carotid stenting. And Dr. Moore, I would greatly appreciate your comments on this because this comes from NDCR. This is 7 societies that joined in the CARE registry sponsored by the American College of Cardiology, voluntary, hospital-based, prospective, procedure-based registry, 141 centers, looking at independent adjudicated neurovascular evaluation of the event, whether it be a carotid stent or carotid endarterectomy, in over 12,000 patients over a 4-year period, with the simple objective to compare and contrast the clinical and the socio-demographics of who is referred to endarterectomy and who is referred for carotid stenting. Now, every one of you just sent that patient, Mr. Smith, to carotid endarterectomy. But look at this data, because I think what we do when the lights are out and who we refer these patients to is very telling, at least in these centers. So here's carotid stenting, here's carotid endarterectomy. You can see this is high-level data in a registry as high level you can get in a registry. And you can see the dichotomies with regards to all these patients. Here you see obviously the procedure type. If you look at the cardiac history, you can see the dichotomy that divides if patients go to carotid surgery or carotid endarterectomy. If you look at further the procedure type with regards to the non-invasive studies, and you look at all of these other issues that were brought up by previous speakers with regards to dementia, with regards to history of seizure, with regards to previous endarterectomy, we see the dichotomy in how we are referring to certain, whether we're referring to the cardiologist, the radiologist, or the surgeon. And here is the carotid stent propensity analysis score, and I think this is the most telling. If you look at the red bar, they're going down. As you look at the blue bars, they're going up. And basically, this is an attempt to balance a large number of confounding variables. If you understand propensity scoring, it's fairly complicated. I don't pretend to understand all of it, but it basically gives us a probability in large cohorts that patients, given their demographics and their characteristics and covariables, will go one way or another. And we see that the more the propensity score, the higher the probability the patient's going to get shunted to a stent. The lower Now, when I'm saying that these centers are cherry picking, I'm just saying that as we look at real world data, as opposed to EVA3S and the SPACE trial and ICCS and so forth and so on, we are going to get more and more data. Now look at here, as with regards to evolving patterns here, carotid endarterectomy is on your left and stenting is on your right. We see patients who are, this data is very provocative in, do you have insurance or not, where you go, do you have heart failure, here's insurance. Obviously, have you had previous carotid stenting done? Do you have a restenosis from a prior endarterectomy? All this is real world. Now, getting back to Dr. Martin's caveats that we always have to question in these 144 patients, do they reflect what you guys do in Davis, Sacramento, or in the Bay Area? There are potentially important health status and socioeconomic factors that were not really looked at, and they may cause differences between the two groups, and that importantly, non-invasive data that was assessed locally, as these were all ICABLE certified laboratories or hopefully competent radiologists, they may introduce some bias in one way or another. So carotid stenting, in summing up for me, I think we understand that real-world data now will help us define which better patients to select for one or the other. I think, importantly, just like PCI and just like any other procedure, volume counts and they reflect your results. And carotid stenting results do depend on experience, similar, again, just like anything else. Now, I want to really finish up on what just happened just a couple days ago with regards to the federal government here. The regulatory process now has been thrown upside down because several weeks ago, the advisory panel to the FDA voted 7-3 with one abstention to approve carotid stenting, the Abbott device, for standard risk patients. Here is, as John alluded to, the indications now for standard risk, greater than 70% symptomatic or 50% by angio, or asymptomatic greater than 70% or 60% by angio. And I do think the CMS issue is now going to be provoked again. And we have, as clinicians and society members, an opportunity, I believe, to deal with the reimbursement, because CMS has been resistant for multiple years and has not taken the recommendations of the FDA. That's not their job to, as far as they're concerned, to rubber stamp the FDA. But again, we have to coordinate these two organizations. They have started to talk a little bit more. The FDA, the CMS will have more data to look at. They have the data from an $80 million trial. And hopefully, just as John alluded to, with more collaboration between the societies and variety of specialists, we can do ultimately what the best thing is, not for ourselves, but for our patients. Thank you very much.
Actually, to invite back up Krishna Rocha-Singh, my very good friend and colleague from Viva. And Krishna is going to talk about optimizing outcomes with carotid artery stenting.
Thank you, John. I was given the title that was, I think, open to interpretation of optimizing outcomes of carotid stenting. And I want to reflect a little bit upon some of the comments made by Dr. Moore, and understand some of the comments made by Dr. Martin previously, that we can look at the same data, we can read the same paper, and we can come to different conclusions. What I'm going to suggest that in the next 20 minutes or so, and just answer this question. Would you, if you're a neurologist, say discontinue the aspirin and add BID Agranox, like they do frequently with regards to patients in this category, potentially? Would you immediately hospitalize this patient, heparinize this patient, and call a surgeon and say, I want an OR slot for this patient the next morning? Or would you say, I'm going to add clopidogrel? Dr. Moore alluded to that, and refer to an endovascular specialist, whether a surgeon or a cardiologist or a endovascular radiologist for consideration of carotid stenting, or would you say, the hell with it, I'm just going to start some Coumadin, warfarin, because that's what I've done for so many years? Well, here's our first case back July 1st, 1997. And I show you this case to understand that we have evolved. We have evolved exceptionally in the past. For how many of you were CREST investigator certified, got the little CREST pin, and put it on your lapel? Just one. How many of you were CREST certified surgeons? One. So I think that's actually a very interesting comment with regards to some of the issues here, because I do think, to Dr. Moore's point, I think it's all about, just like anything else, experience and judgment and knowing what you're doing. And being there a lot, and that's what we want for our patients. So let's go through this, and I want to reflect on this later on in my talk, and I want you to answer the question to you. So 65-year-old gentleman, okay, think about CREST, think about the SPACE trial, think about EVA 3S, think about all the trials that we've had. Here are the typical risk factors: 2 months, 2-week history of amaurosis, question mark, look at these symptoms: right-sided hand weakness, typical coterie of medications, and here's his physical examination with a left-sided bruit. You do have an indication to do a carotid duplex Doppler that you'll get reimbursed for, not necessarily because of the carotid bruit, but concern of stroke, and then your neurological examination. And you could be a general internist, you could be a cardiologist, you can be an ER doctor. What do you do with this patient here? Here is his ECG. Here's his carotid duplex Doppler done by an ICAVL certified laboratory, suggesting a high-grade stenosis. The MR is also done in a collaborative manner, and this patient is being set up to define the best medical therapy for him. And so what would you do next? So is really looking at this data and defining quality of care. Because as someone who's been stenting carotid since 1997 in the wall stent trial, I think all of us have the interests of our patients at heart. And we understand that, as far as I'm concerned, and I think a lot of cardiologists, our CREST has changed a lot. And I think there's an establishment of equipoise in certain specific patient populations. These are my disclosures. I am on an advisory board of at least several companies that make carotid stents. That really has nothing to do with this talk. So here's a case presentation. I want you, first of all, I always like understanding who I am talking to. How many of you stent carotid arteries? Okay.